Alli, we're hearing all about GLP-1s, Ozempic, Wegovy, Mounjaro. What do you know?
There's so much to know, or maybe we don't know about. How do these things control weight management? What do they do to our appetite? What happens when you go off of them? I'm hearing these questions. What about you?
Well, lucky for us and our listeners, we have the leading expert on GLP-1 use, on how they work, their benefits, the myths about GLP-1s, the future of GLP-1s. And today we've got Dr. Spencer Nadolsky with us. He's an obesity specialist, a physician, the founder of joinvineyard.com, and he answers all kinds of questions and provides all kinds of enlightenment for us.
And we had questions, so y'all just wait. And before we dive in, we want to give a shout out to our Girls Talk Healthy Aging listener, Miss Janet Spillers. Thanks for listening. Let's dive in. Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Alli Kerr.
And I'm Shawna Kaminski. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey.
What a hot topic we have to talk about today. And I'm so excited to have you here with us, Spencer Nadolsky on the Girls Talk Healthy Aging. Welcome to our show.
Thanks for having me on.
Let's say who you are. So you are an obesity specialist, and this is a hot topic. And you know a little bit about this things called GLP-1s that are making lots of headlines. And so we're going to get to dive into some of that with one of the experts. And you are doing a lot to get the word out and to help people to understand what's true and what's not true about obesity, GLP-1s, and more. So I want to hear about how you got involved in obesity to begin with. Can we start there?
Yeah, I grew up in an athletically, academically minded family, used exercise and nutrition to get good at sports, and ended up wrestling and playing football in college. I was over at UNC Chapel Hill, North Carolina, and really used it to be good at sports. But when I went to med school, I was like, oh, what do I want to do for a specialty? I want to get people healthier. I want to get people lean and mean, and I don't want them they don't need to obsess over nutrition, exercise like me, but like maybe to improve their quality of life and live a little bit longer and better life. And the obesity especially wasn't really a thing back then. People talked about it. There was some older drugs that basically all the obesity doctors would do is give out basically amphetamines. Not really. They gave out phentermine, which is a decent drug, but that was like all they had back then. But it really progressed quickly. While I was in med school, that's when these drugs were coming out for type 2 diabetes, just coming out. The first one came out in 2006, so right around when I started med school. And really got into like, okay, this is kind of this new and upcoming specialty. And I thought it was perfect to basically take my obsession for diet and exercise and bring it to the next level to help, people that are struggling go from zero to doing something. So they don't have to run a 40-yard dash, 4-second something 40-yard dash, or bench press 400 and some pounds, but like to just start moving and improving their life. So that's the gist of how I got into it, is really into helping people reduce their risk of heart attacks while also feeling better about themselves and living a better quality life.
And you mentioned the different drugs, and I actually downloaded your book, The Fat Loss Prescription. And
oh yeah, that's a 10 years. It's 10 years old, but it's still decent. It's still decent.
There's still some good stuff in there. And one of the things that I was surprised about is all the different medications that I did not realize that were back then when you wrote that book.
Yeah,
the different medications that were being prescribed that were available, but nothing like what we have
nothing
today.
Like we have today. It's amazing what happens in 10 years.
Yes, and that's exciting for sure. And also people might look back and say, oh, a lot of times we look back and we're like, oh, well, they didn't, they were wrong. But it's, we didn't know what we didn't, or we didn't have what we didn't have, what we have now.
Yeah, so some of the GLP-1 class, 2006 was the first one approved. It's called Byetta, or exenatide. That one was like a twice daily injection. So I mentioned that in the book. And then the next one that came out was called liraglutide, which people know as Victoza or Saxenda. That was a once daily injection. And that one helped. It was like around 7 or 8% total body weight loss. So let's just say you're, 200 pounds. I mean, you can expect to lose maybe like 15 or so pounds on average.
So if you have obesity, if you're obese, 10, 15 pounds is not going to really put a dent in things.
Yeah. So it wasn't, I mean, people still use it a little bit, and some people respond more to it and do okay with it. But like on average, it was really expensive and it didn't have a ton of weight loss. So, I used it right when it came out for patients, but like insurances weren't covering it. And so that's what we had back then. But we had some of the older drugs I talk about in the book. Phentermine was one that a lot of the obesity doctors were doing, and then they came out with a combination of phentermine and topiramate, which is like Topamax. People use it for migraines and seizures prevention, but a little bit can actually help with weight loss. And some of those were okay, but like these newer versions are just so powerful, and really like double, if not triple, the weight loss that we see from those old medicines. So yeah, nothing was really necessarily wrong that I know of in the book. For anybody listening, the book I wrote it like right out of residency. It was like 2015, I think I published it. In fact, I just saw the Facebook memories pop up. So I'm in the middle.
And I didn't mean wrong in your book. I just meant like in science. A lot of times,
usually
when things change, people think
evolving. But
I thought your book was great, and you had a lot of lifestyle stuff in the book that was about how to change your lifestyle. So I still think it's got such valuable info.
So I'm writing a new book that kind of updates a lot of all the stuff that incorporates the newer medicines But it's amazing what and 10 years from now, I don't even know, there are certain drugs in the pipeline that like we're gonna see just massive amounts of weight loss and changes in people. It's actually pretty crazy to think about. So.
Well, the good news is that medical technology or advances in medicine are going to be helping with obesity, but some of the tried and true lifestyle hacks or habits, I don't like to call them hacks because they're really lifestyle habits that are important. Some of those principles aren't going to change.
So we have certain principles that like they come and go, though. We see cyclical natures of like there's keto and then there's carnivore, and these things come and go, and it's really interesting. It's not like a ketogenic or very low carb diet is new. This has been out for decades, and then a new spin on it will come. But in general, the principles still remain of what we need to do. And that's why it's really funny, because if you're around long enough, and I'm still relatively young, but like when I was younger and in these internet debates, a lot of the older, wiser folks would say, "Oh yeah, a decade or two, I saw this argument before, and now it's coming back." And then now I'm seeing it, now that I've been around for a little bit longer, 10, 15 years, now seeing these waves of fads. It's really funny to see.
Well, let's dive into, the whole idea of GLP-1s, because they've really come on the mainstream quite quickly. So if you could just help dispel some of the biggest myths and misunderstandings that you hear from patients or the media, and maybe summarize how these drugs actually work for obesity.
Yeah, a basic physiology lesson. It's important to know the incretin effect. So this is the effect where they found this out in the 60s with certain experiments where they injected glucose or sugar into your veins versus had people drink glucose, and they were just able to measure insulin responses finally, and they started looking at the differences in the insulin response between the two, and they saw that people were having higher insulin response when they drank the glucose versus injecting it directly in the veins. And it seems paradoxical, because you'd think that the sugar would get to the pancreas, which is what spits out the insulin, faster. But when they drank it, more insulin happened. So they called it the incretin effect, something about some secretion of hormone from the intestines or something that was going on to have more insulin response. But they didn't know what these hormones were. They didn't know what was causing exactly. And then over the years, it's a really, really interesting story. It gets really dense with how these researchers discovered this. But over the decades, then from the 60s, they started figuring out, the different types of incretins. And in the 1980s, they figured out that GLP-1 was one of these incretins. The problem is GLP-1 is broken down very quickly in our bodies by our own enzymes, and so they weren't sure exactly how to use it as a drug, but there is some interest in it, and over time, somewhat serendipitously, a researcher was looking at Gila monsters, these little lizards in the desert. They could go a long time without eating, and so they thought maybe there's something that has to do with blood sugar with them. They didn't know that there was a GLP-1 component there, and they found that these lizards in their venom had a component that was called homologous. It looked like our own human GLP-1, and they kind of broke it down to the non-venomous part and used it in experiments and purified it and saw that, hey, this thing is actually resistant to the enzyme. It's called DPP4 in our body, so it's not broken down as quickly. And then that got developed into the first GLP-1 called exenatide, or Byetta is the trade name. Then scientists then took our own, started modifying our own GLP-1. They've just brilliant researchers finding ways to help modify our own peptide to make it not be broken down, because that was the big issue. It's this thing's not going to have an effect. You can just inject it all day and it's just broken down so quickly. So that's kind of what happened. So it's good to understand, to have that basic knowledge, because some of the myths out there, like supplements or diets that can increase your own GLP-1, people are using a lot of that as marketing, and it's really a lot of scams. So people are like, well, here's the natural GLP-1, just drink olive oil and eat blueberries or eat a ton of oatmeal. And so it's yeah, oatmeal can be good for you, but it's not any effect on GLP-1 that's going to have that weight loss effect. There are certain supplements out there that are here, take this special supplement. It'll increase your GLP-1 by 30%. And it's who cares? It doesn't really matter. It's like pissing in the ocean. It'll break down so quickly, it won't have that effect. So probably one of the biggest myths that bothers me is that all these bandwagon folks are jumping on GLP-1 supplements or GLP-1 diets. And the diet could be actually pretty good. It's just not the GLP-1 boosting effect of the diet that makes it good. So that's myth number one. The other myth, there's so many myths. Actually, in the beginning, they thought that these drugs, because they worked on the pancreas and they could help actually stabilize or even help your beta cells. The beta cells in your pancreas are what make insulin. So there's thought of maybe these things could cause pancreatic cancer or pancreatitis. Lots of studies done. It doesn't look like there's any difference between the active experimental drugs and a placebo statistically. So they think that it seems to be safe on the pancreas and probably helpful. The other thing is thyroid cancer. There's a big black box warning on the label that says, warning, thyroid cancer. Well, it's a specific type of thyroid cancer called medullary thyroid cancer, and it's rare. It comes from specific cells in your thyroid, whereas the other, follicular and papillary thyroid cancer, they come from different cells, but C cells in the thyroid. And it was seen in rodents. The rodents had hypertrophy or enlarging of their C cells, and then looked like there was a signal for thyroid cancer, medullary thyroid cancer, that rare thyroid cancer in rodents. Well, in humans, we don't actually have GLP-1 receptors readily available on our own C cells, but rodents actually do have those receptors. So it's thought that this isn't an issue in humans. It's being constantly, they're monitoring it closely, but it doesn't look like there's a strong signal there. So the studies that have been done on cancer are kind of interesting because it looks like, if anything, there's a reduction in at least obesity-related cancers, which makes sense. So things like breast cancer, anything related to excess adipose or fat tissue. So, other myths are like stomach paralysis. So when people say that, most people are thinking, "Oh my God, my stomach just won't work anymore." The drugs actually do have a physiological effect. GLP-1 itself has a physiological effect of slowing down gastric emptying. So, when you eat food, it goes down your esophagus, into your stomach, and then goes into your intestines. So gastric emptying is the contents from your stomach going into your intestines. And so the GLP-1 does have a slowing effect on that. That actually goes away over time the longer you're on the drug. Some people report that they've had the technical term for it, or medical term, is called gastroparesis from the drug. Now, if you start the drug and your stomach emptying will slow down, there's nothing to say that it's permanent. I've never seen it in any studies, but there are people out there, anecdotes or case reports of people claiming that their stomach doesn't work anymore. I haven't seen it personally. You see these lawsuits, but if it happens, it would have to be rare, extremely rare. But the drug does slow down emptying. So when I start asking people, online, someone's like, "I had gastroparesis from this," or stomach paralysis. I'm like, yeah, the drug will, if you're on that, you just started, it will slow things down. So if you do some testing, it will look like maybe you're not emptying, but once you stop the medicine, it's not permanent. So I've never seen anything permanent, but again, there's some lawsuits out there. Maybe there's, out of the millions, maybe there's one or two. I don't know, but that's kind of a big myth.
And then you're also eating less, so that's going to slow how much is moving through if you're not taking in as much, right? Would that be, or do you think some people might think that that's their stomach not working properly because they're
so what happens? These people go to the ER because they feel nauseous. So one of the most common, and this is a real side effect, one of the most common side effects, the most common side effect we see is nausea, and if it gets really severe, they start vomiting. So a lot of times those people are going to the ER. The ER is saying, "Oh yeah, you have gastroparesis," but it's not. They shouldn't call it that because that's like it's a pathology, and the drugs physiologically do slow down your gastric emptying, and it's not permanent. So it's possible these people are getting diagnosed with gastroparesis when it's just like, well, no, this is a side effect from the medicine that occurs in the beginning. So that's what I think is happening. To go back to your question of like how these drugs work.
We're going to interrupt this interview for just a second because we've got something we want to make sure that you know. If you're struggling with your health, with your fitness, if you don't know where to start or you know what to do and you're not doing it, we're here for you. And all you need to do to get our help is to reach out to Shawna and I at our email, sapodcast23@gmail.com, and we're happy to help and we will be in touch. Now back to the show.
Well, so these drugs work for type 2 diabetes they do slow down the gastric emptying a little bit, which means less sugar is getting into your bloodstream faster, so it's a little bit slower. That's a small component, but they also help work on the pancreas to help release more insulin, and then they work so well for weight loss, which helps with blood sugar control. In the brain, it's actually the brain. They help with appetite, and people are like, well, no, they do a lot more than that. It's like, well, no, there are multiple components of appetite. So it's not only just feeling like not hungry. So people don't really truly understand like the different components of appetite, because hunger, I mean, we've all felt, if you haven't eaten and you're like, oh my God, like my stomach is growling, I need to eat, versus like, I'm kind of craving food. You're not necessarily hungry, you're craving. But then there's also like wanting and thinking about food. People refer to as like food noise, like constantly thinking, like intrusive, like all I can think about is is there going to be enough food at dinner? What's the dessert going to be? And not specifically about specific foods like a craving. Like I could really go for some chocolate or some chips right now. It's just thinking about food. So the medicines work on all those different components, not only hunger, feeling satiated sooner after eating, cravings. You don't crave as much. People don't crave as much alcohol or other addictive-like foods. I don't like to say addictive foods, but addictive-like foods. And then also just not thinking about food as much. So then you don't. It helps you basically lower the amount of calories you're eating without consciously putting a ton of effort into it. It almost normalizes appetite to where you eat like somebody who doesn't struggle with their weight would eat like. So that's how they work. There are newer drugs coming out that do increase your metabolic rate, that basically help you burn more calories, but these drugs help basically reduce the amount of calories in, which is nice. So yeah, those are the big things. Other myths that I see, people are worried about muscle loss, and like that's what I do a lot of work on that. I'm doing research into that. I'm a big proponent of resistance training, but it doesn't seem that the drugs increase muscle loss beyond what you would see if somebody just did a really low calorie diet without lifting weights and eating protein. So I don't like, it's not a myth. You do lose muscle if you don't resistance train and eat protein, but it's not like the medicines are specifically eating away your muscle, if that makes sense.
It also seems that for every myth, there's a reasonable solution. For example,
Yeah,
just you're talking about muscle loss, but if someone
yeah,
is on an extreme diet and
yeah,
not eating protein, they're going to lose a similar amount of
yeah.
muscle.
That's right.
Or if someone has, very slow digestion, they can maybe change their eating habits such that maybe they could reduce fat a little bit, increase fiber and fluids a little bit to keep
Yeah,
things moving. So,
yeah,
but I also think that this is a point that we should mention, is that if you're going and getting GLP-1s from not a reputable source, you're not going to get that information that's vital to your success. So can you speak a little bit about that?
yeah. I kind of rail against this online, and obviously I'm biased because I have my own clinic, but that I created it because of the necessity that I saw out there. A lot of these places they're just pill mills, and I think access is a big issue. Like if you go to your regular doctor. A lot of regular doctors don't feel comfortable doing it. They are now. They're feeling a lot more comfortable, but even still, you only get a few minutes with your regular doctor. You're not going to get all the good information, and so like if you're not able to go out on your own and kind of do your own research, where are you going to get the resource? So like with me, all of my patients get their very own dietitian that they get to talk to whenever they want to. We have all the resources of weight. We have weight training programs and anything and everything you'd ever want, of course, with direct access to your doctor too. But yeah, what we see is, a lot of the insurances and these places will show the statistics of like most people who start these medicines stop them. And there are two reasons for that. First of all, they're expensive. So if your insurance stops covering it, you're not going to pay for it anymore. And two, the GI side effects are real. Those aren't like, it's not like these drugs are amazing and they're side effect free. No, you can have side effects and they can be moderate to severe, but they can be minimized with the right team. And you can also be worked through those side effects with the right team. So, for example, if a patient's having nausea on the low dose and pretty bad nausea, and the next month the refill comes up, the label, if you just follow the label, you just keep cranking up the dose. But that person shouldn't go up in their dose because they're going to get worse side effects the next month on the higher dose. They should probably wait until those side effects at least get down to a 1 or 2 out of 5. It's kind of a subjective thing, but like you should wait till the side effects start improving if they're moderate to severe before going up in the dose. Certain things you can do from a dietary standpoint that my dietitians are amazing at, but like high fat foods, sure, you can eat them if you want to stress test it, but those tend to be the ones that cause the most nausea and sometimes diarrhea. If you're not eating fiber and drinking enough fluid and moving, constipation. That's the second most common thing we see. Constipation is always a risk, so we try to get ahead of it by plenty of fiber and fluid. So all those things, those GI side effects, can be minimized, and some people unfortunately still get them despite their best efforts. But a lot of them can be prevented, from what I have seen.
With fluids, what fluids do you recommend if someone is dealing with constipation?
Yeah, I mean, water obviously, but like, if they need like prune juice or things like that are nice to do to get people moving again. But in general, like if they're eating enough and they're just not drinking enough, that can cause a problem.
And I want to go back, and I appreciate you talking about the supplements and how that can, that you can buy this. One of the things that I see are natural GLP-1.
Yeah.
That's something that I see advertised, that you don't have to take the pharmaceutical route. You can get this natural supplement that acts like GLP-1 without the GLP-1. And so I appreciate you speaking to that. And I wanted to just maybe expound on that a little bit, because I know if I'm seeing it, our listeners are seeing those things being advertised. And I just like to think of the why. Like, why is that a thing? Why is that popular, and who benefits? And I think that, the supplements, a lot of these supplements that were out before GLP-1s became so popular and we saw the results from them, they were able to sell these drinks and these things that were going to help you lose weight. And then GLP-1s came on the mainstream and people started losing more weight and getting more results. So that had to be a hit to a lot of these companies. So, and then I think the people that listen to these ads or see these ads are honest people, and they can't imagine someone would lie or misinform them about what these things do. But they're really, and this is something that we really work to help our listeners understand, is how much money makes the world go round. And when it comes to these things, can you speak to that? And I'm sure, we don't want well-meaning, innocent people getting roped in and spending their hard-earned money on these things that are not effective.
Yeah, I mean, I think you hit the nail on the head, because like these places were making money scamming people with their crappy supplements before, and then all of a sudden GLP-1s come in. It's like, oh, these things actually work. Now we need to find a way to scam people, and it's like, well, let's just call them natural GLP-1s. And the people that maybe can't afford the drug, which they're getting cheaper and cheaper now, to where like it's not as much of an issue. And actually, people are going onto the gray market. I don't recommend it, but people are going to do it anyway. And you can get the drugs for a fraction of the cost.
Because people are getting drugs. Some insurance companies are, if people change their insurance or something happens, or their insurance just won't cover it. So that is like you said, access. That's a challenge.
Yeah. So then, but if they don't want to do the gray market, which I don't recommend it, but their insurance doesn't cover it. They don't want to do direct, like Lilly Direct or NovoCare. Those are like the two main direct pharmacies that are doing it with the real FDA approved stuff. So then you got these companies going, here, well, come get our natural GLP-1. It's cheaper and it works. And it's like they're just lying to people, because they won't even have any studies. They'll just say this stuff can boost your GLP-1 by 30%, but as I talked before, it will do nothing. It's your own natural GLP-1 will be broken down so quickly that it won't have any of the effects. I do like to say, though, we have drugs that actually block the enzyme that breaks down GLP-1. They're called DPP-4 inhibitors. DPP-4 is the enzyme that breaks down GLP-1. And those don't even result in any weight loss, despite increasing our own GLP-1 by 2 to 3 times. So they work for blood sugar, which is nice if you have blood sugar issues, but for weight loss, they don't help. So any of these supplements that claim to do whatever, don't expect to lose any weight. You're just going to lose money. So highly recommend against.
You're going to lighten your wallet.
Yep, that's right.
I mean, that seems to be one of the issues that people hold against GLP-1s, because they'll say, well, if I go on this medication, I need to do it for life. What are your thoughts on that?
Yeah, it's the way I always say is like obesity is a chronic disease, and people don't understand that. They think, how is it a disease? Because like it's not like it's tuberculosis or something like that. It's like, no, there's what we call non-communicable diseases. So heart disease is a disease, and they're like, yeah, but it's a choice. How can it be a disease? It's a choice. I'm like, there are other disease, regardless of, I don't believe it's a choice, but regardless if it's a choice or not, that is separate from the concept of what is a disease. It just meets the definition of a disease process. And part of the disease process is appetite dysregulation and all the inflammatory and hormonal changes that occur when you develop too much adipose tissue. So when people try to lose weight, their bodies fight against them. And in turn, it's big in the appetite centers of the brain. So you're like, okay, I'm going to go ahead and try to do this diet and exercise thing, and unfortunately most people won't respond as well to it because their brain is fighting them. They're like, no, you're hungry, you better eat more, go eat that pizza in the break room, all these different things. That's where the medicines come in. So when you start one of these medicines and you lose weight, there are some percentage, it's a small percentage, 10 or so percent, maybe 15 maybe percent of people might be able to come off and keep most of their weight off over the course of a year. I don't know what happens to them after a year. Those data aren't out yet. But the majority of people will have some form of weight regain. What I always tell people is that most people will have to stay on it, but they may not have to stay in the highest dose. They may be able to go on very low doses, actually, and even spread it out over time. Some people might have to stay on the highest dose forever. Some people can do low dose. Some people can come off. I always tell people you don't have to come off. They're designed to be able to be taken indefinitely. But if you want to try, I'll help you do it. But other people are like, these are just a crutch or a Band-Aid to get you to the healthy lifestyle. It's like, well, no, unfortunately, when you remove this powerful biological drug that's helping your appetite centers, you remove it and your appetite will come back and stronger now that you're at a lower weight, because your body's going to really fight back against you. So most people have to stay on it, unfortunately, and it doesn't have to be the highest dose. Some people can get away with lower doses.
So we hear about microdosing, and so maybe those that have had success with weight loss, they can go on a smaller dose or even a cyclical dose where they come off completely and then maybe go on a small dose. Is that there's lots of options. It's not necessarily binary.
Yes, there are lots of options, and it really depends on the biological drive from that person. It's hard to predict. Big pharma, like the thing is little old me with my clinic and however many patients we've seen and over the years, but like big pharma is it's $1 trillion question because they're trying to study it too. Why do some people respond so well? Like I have some patients that lost 100 or so pounds on the tiniest little dose, whereas other people I have to crank them up to the highest dose and they barely lose 5 to 10% of their weight, or even less sometimes. I had a couple patients the other day, it's rare, that just didn't lose, like barely lost a few percent of their weight despite the highest dose. It's like they didn't feel it. And it's likely has to do with genetics, receptor sensitivity of the GLP-1 and all these different other things. But some people respond very well to it. So yeah, some people could go down to a very low dose, or like you said, even be cyclical with it. Maybe take it once a month. I have some people do that. Some people want to come off of it for a few months, see how they do, and then they're like, nope, can't handle it anymore. Go back on it, then come back off. The key is very close monitoring. I don't want to be a guru and say I got the special formula. It's the best thing to do is just monitor closely with your doctor and ideally a dietitian because if your weight starts creeping up, you want to jump in and intervene sooner so you don't regain all your weight and then try to go back on the medicine again.
And what about the dosing? Are there what kind of options are available right now with the FDA approved versions? Like if someone doesn't need as much, is it that they have to just do it once a month, or is, because these come in a certain dosing, right?
Yeah,
Different
yeah,
levels.
yeah. So that's the kind of the issue with the current pens. Although they're switching them, they're quick pens that you're able to click doses, and up in Canada they actually have, in some other countries they have it to where you can do in between these therapeutic doses. In the States they have fixed doses in the pens. In the vials though, that you can get directly from the manufacturer that doesn't go through insurance, you can do any little difference of dose. And I prefer that, because some patients, when they go from, let's say, so tirzepatide is Zepbound or Mounjaro, as people know it by, it starts at 2.5, then it goes to 5, then it goes to 7.5, then it goes to 10, 12.5, 15. It goes in 2.5 milligram increments. And sometimes when you jump up an increment, it's too much. So then I give, let's say they wanted to jump from 2.5 to 5 milligrams. And I was like, oh, that first week it was like terrible. They're like not doing well. So then I'm like, let's actually try 3.5 milligrams next time. You wouldn't be able to do that with a pen. You'd have to split the pen. You'd have to inject that pen into a sterile bacteriostatic vial, and then start. It's actually a real pain. So people do it, but it's ridiculous. So having the vials, and then in the future they're going to have the clickable pens to where you basically click and you can kind of do in between doses. Hopefully Lily's not listening to this, but they want people not to do that, but we're all going to do it. We're going to do that.
Right. Based on what you're seeing with your patients and what their needs are, you need something more that you can tailor more to that patient.
Exactly.
And they don't have that available. And that is one of the things that I have seen and heard patients talk about is, it's like, this is too much, but then this, I'm stuck. So it's like, what do I do? And then with people that are interested in these medications that maybe don't qualify through their insurance, maybe they have a few pounds to lose, or they're going through, for our audience, we have ladies going through menopause, perimenopause. Where do you see this as far as now, or maybe where it's going with GLP-1s? What do you see happening with people that are not obese? Do you see that as I know people are using them now that are not obese, but
I think it's inevitable that I think a lot of people are going to be taking these drugs. The issue that I have with it is we don't have enough safety data in leaner individuals. And I'm trying to think of what would even be the issue. Well, there are rare side effects that, like that maybe happen that we don't see in the trials. And if millions and millions of people are doing it, then all of a sudden you start seeing those in people that didn't need the medicine in the first place, other than like a little bit of vanity weight. But let's play it out that those things are extremely rare, and even just losing 5 to 10 pounds is is a benefit worth taking the risk for. The only other thing I'd worry about is the same thing that you see with weight cycling or yo-yo dieting is, you use it to lose 5 to 10 pounds. You come off of it, you regain that 5 to 10 pounds. There's the concern that you lose muscle while you lose some muscle while you, despite your best efforts, maybe some, and then you come off of it, and then you regain that weight. It's possible that you worsen your body composition over time. Honestly, I don't think it's a big deal if you're weight training and you're being very diligent. But like, I could see people that are just using it like they do crash dieting or yo-yo dieting. That would be the concern. I don't have concerns with like more of the fitness crowd who know how to do this right in terms of body composition. I worry about the I don't know if the term would be fair weather weight losers, where they just kind of, I don't know what the term is. What is that?
I have an event coming up. I'm going to take GLP-1 and then I'm going to stop.
Yeah, that would be my concern. And again, I honestly, I think it's gonna happen.
It's already happening.
It's happening. You go into the med spa, you get a compounded version. I don't recommend them, but like, I'm not, I'm not going to prescribe it, but there are a lot of people that are doing it. You can pretty much get the stuff. You can buy the stuff off the gray market and just make it in your
Yeah.
bathtub yourself, which I wouldn't recommend due to contamination
Wow.
and purity. But people are doing it. I don't know.
Wow. And then do you think with the dosing changes that there'll be more dosing? Because, I mean, of course, just like everybody, I mean, this is such a big thing and so many people are already finding
Yeah,
ways to use it and the market is going to meet. I think
yeah,
the money is going to want the market is going to want the
yeah,
money. And so, fun will there be, and I know we haven't even touched on like pills yet versus injections that are coming in, but do you think that you'll have more dosing options because people that are not obese are taking these from like an FDA approval kind of
yeah. So
thing?
more studies will come. Here's what I think will happen. I don't think these drugs will be FDA approved in like lean, healthy individuals anytime soon. But I think there's going to be a lot of off-label usage. I think that's where the clickable pens are going to come into place, and maybe the vials. Um, I, if I'm using a crystal ball, I'm thinking most people will be taking these medicines in 10 years. Like, even myself, I don't take it, but
I agree. I mean, I think I think I would
I,
not be surprised by that.
I wouldn't take it for weight loss, but I'm a lipidologist as well. And, it's kind of like preventive cardiology and cardiometabolic specialist. It's not a real specialty. If I were to call myself anything, that's kind of the specialty I would use beyond obesity. And like I'm looking at it, going like, you know, I think it's possible in the future I'll be on a small dose for cardiovascular preventive purposes. Uh, and so, like, if I'm thinking that way, and I'm relatively conservative with some of these things, then man, that's just it's the floodgates are pretty much going to be
Mhm.
open. That's why.
You already hear clothing manufacturers are having to really change their sizing, and they have, because people's sizes are changing. And so
Yeah.
you can just imagine the different effects that a smaller human race, especially in
Hmm.
developed like the United States and Canada, like how much that's going to affect so many things in the next 10 years.
Yeah. It is crazy to think about.
So, what are some of the future applications like lipid control, as an
Yeah.
anti-inflammatory? Um,
All of it. So they're looking at a lot of cardiometabolic stuff. So liver disease that's related to our adipose tissue, and like you said, lipid control. It's glucagon, the glucagon component, where retatrutide. There are other newer ones coming out that don't have the triple receptor, but some of them are GLP-1 and glucagon by themselves or together, as opposed to GLP-1, GIPN, glucagon, and so LDL cholesterol. But then beyond that, inflammatory autoimmune conditions, Crohn's disease, ulcerative colitis, psoriasis, psoriatic arthritis, rheumatoid arthritis. Um, I think there's a lot of potential in PCOS, addictive abuse disorders, alcohol abuse, and other addictive conditions. Obviously, so they're looking at it looks like maybe they help with osteoarthritis beyond just the weight loss. There may be something about it that helps with improving the cartilage. That remains to be seen, but that's a new study that came out yesterday. So like all sorts of things.
I'm even hearing
I
people talking about, and I see these things on social media, so this may be a myth, but like that their hair is healthier. Is that
Yeah.
something?
Well, people lose a lot of weight and their hair comes out because of all the
Right.
weight loss and stress. But lots of things. It's pain. A lot of people notice their pain and mobility are just so much better. That's what I'm
Mm.
like. Man, that would be nice.
yeah,
Right.
with
And all the things
aging.
that come with aging and
Yes,
hormone changes.
yeah.
Hmm.
Is there a patient that you can think of that would not be a candidate for GLP-1 use?
Yeah, it's the thinner, frailer patient that like on paper they shouldn't get the medicine, but like if they're going out there to find you can get the medicine if you want to, if you try hard enough. So it's an older, frailer patient that wants to lose some vanity weight. I'd be like, God, I'd be really careful about those patients, just because you just don't want to lose more and then have a fracture. Those are like the people that I worry about most.
Do you see people that are taking GLP-1s losing too much? Is that a concern?
Yeah.
That maybe started it, they needed it and they were
Yeah.
obese, but now they've lost too much. And then, because I've seen this with
Yeah.
my client,
Yeah.
and yeah.
I have it. I have some patients where they're teetering on being underweight, and that's a higher health risk than being overweight. And so but they've seen other doctors, and their doctors are like, no, we got to take you off the medicine completely. But then they're afraid of regaining the weight, and they will likely regain a lot of weight. So I have to sit there and give reassurance that, like, okay, you can't lose any more weight. Like, I will not prescribe this anymore, but I trust you enough that we will monitor this closely. But yes, I've seen some of these people. I'm like, you probably lost too much weight here. And so now I'm trying to help minimize the risk of worsening things.
Like loose skin, because a lot of that, what I've seen is clients that don't understand that they've lost the fat, but they're not going to lose that loose skin by continuing to take that same dosage and continuing to lose more pounds on the scale. Like that's one of the disconnects that I've seen in practice. And so like, can you speak to that as far as, because when you do, especially if you, and this is with someone who's been obese, so they have a lot of loose tissue and loose skin. So how can we help those folks understand what fat loss is and what fat loss is not?
Yeah,
at a certain point.
It's one of those things where it's inevitable that there will be loose, like, it's hard to prevent it. Maybe losing weight slower, maybe lifting weights, maybe taking some collagen supplements and stuff like that. But like, it's not, in the end, it's like if you're losing a ton of weight, I'm talking in like 30, 40, 50% of your weight, there's likely going to be excess skin. And unfortunately, there are a lot of charlatans out there trying to promote their supplement to prevent it. But like, in the end, you're probably going to need surgery if you want to do something about it. You don't have to do something about it unless it's really bothersome. But yeah.
Well, the fact is they're going to be healthier even if they have a bit of loose skin.
Yeah.
And fun fact, I'm in my 60s and I've not really been overweight, but I have loose skin.
Yeah.
It's just a factor of aging. So we have to kind of keep that in perspective. But I think it's important to manage expectations that even if you lose 30% of your weight, you're not going to have a bikini belly necessarily. You might look different, but you're going to feel a whole lot better.
Yeah, that's right.
So throughout this whole discussion, I'm just reminded so strongly that, and I want our listeners to know that one of the most important factors of considering a GLP-1 or use is getting the right medical care. So tell us a little bit about, what you're doing, and if we'll have links to you in our show notes. And of course, we want to promote you because we know that you're offering some of the best care. So tell us a little bit about how people work with you.
Yeah. So our patients, when they sign up, they get their own doctor. They don't get a pool of doctors where they send a message and it's a different doctor every time. That's most of the other programs out there. They get their very own dietitian. They get to direct message us. We have a full resources and all the everything you'd ever need. So the biggest thing when starting these messages, you need very close monitoring, at least when you're starting it. And then as you're going through your journey, you want to have somebody there to fine tune and optimize things so that, like, to make sure that you're not losing weight too quickly, to make sure that we're helping with side effects. And then go beyond the GLP-1 medicine. So like monitoring your cholesterol and even your thyroid and adjusting your thyroid if you need to. We do a lot of primary care like things and endocrine type things that are related to GLP-1. And we do it in real time. So you don't have to wait days to hear back from somebody that doesn't really know you that well. We really want to get to know people and understand them so we can optimize your journey. But the cool thing is that really the dietitians are there too, that you can meet with them as often as you want to help basically keep you accountable and strategize ways to optimize your journey. So, and they can obviously meet with the doctor too, but people love the dietitians a lot because it's like becomes their own accountability coach as well.
And to be clear, this is telemedicine. So
yeah, it's all via telemedicine.
So you don't have to be in Michigan where you are.
Yeah, that's right.
Would this also be available in Canada where I am?
Someday, I hope. It's
Okay.
it's always a medical
The
legal
dream. All right,
law,
we
so,
need you up here too.
yeah.
And if you had a wish for our listeners today, Spencer, what would it be?
I would say that if you're considering a GLP-1 medicine and you just feel shameful about it, don't feel shame. I take medicine for other conditions that I have, and I have to take them forever. So make sure you get do some reading about it. But that would be the wish, is just don't feel shame if you have to take a medicine.
Alli?
My wish is that these medicines we continue to learn more and find more ways that they can help us move forward, whether it be weight, whether it be other disease processes, and we find more ways to make dosing more appropriate and fit the person.
And my wish is that we just have more and more valid physicians that are promoting research and science-based information like you, Dr. Nadolsky, and that people get the right information and lean towards the experts, not the internet, social media experts.
That's right.
Unless you're listening to Dr. Spencer Nadolsky on the internet, because he is very active.
Yes, exactly. Yes.
I would definitely say go and follow Dr. Spencer Nadolsky on Instagram. I think that's where is that where you post mostly?
Yeah, that's right. Mostly, I post everywhere, but if you, that's usually where I interact the most.
Yeah, and that's where I've found you and been following you for years. And so thanks for all you do, because I know there's not much return on those social postings. It is a passion project. And so, we're wishing for the best for joinvineyard.com and for, having a legitimate way for people to find care for GLP-1s.
Thank you.
Thanks for listening. You'll find me, Alli, on Instagram at Alli Curve Fitness. And you'll find me, Shawna, on Instagram at Shawna Kaminski. Feel free to pop us a DM with questions and or feedback. If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience. Until next time, be healthy and be happy.